everybody.
Oh, I'm muted again. Hi, everyone.
Lucy, you're always on mute. So, how is everybody today? Welcome to tomorrow's Podiatry, and today we'll be talking about independent prescribing. So, we got the lovely Alan Borthwick on today. Hello, Alan.
Hello, Sophie. Thank you.
So, how's everybody been since last time? Lucy, you want to start?
Good. Yeah, so I've been doing lots and lots of stuff at uni, but today at work, because I'm an apprentice, I've been running my own supervised high-risk diabeticals clinic, and I've also had a lovely student from Northampton Uni as well coming and shadowing me and one of the other podiatrists. That's been really interesting.
Oh, fantastic. Well, related to prescribing, we are currently doing our pharmacology, and on Friday we were taught how to administer local anaesthetic, which was quite exciting. We had this weird, almost like curved felt type thing that mirrors the skin. So we were taught how to decant the container of local anaesthetic, how to administer it, how to be careful with needles as well, and then calculating maximum dose. So yeah, very interesting. Yeah,
that sounds fab. I think we've just about lost Freya and Gaia.
I think we have. Oh, hang on, let's see where they've gone. Gaia says she can't hear any of us. That's no good.
Oh, no,
hello.
Can you hear me?
Yes, we can hear you.
Good. Sorry, I don't know what happened then.
So Freya, we were just talking what we're doing. What have you been up to?
So today, I'm a third-year podiatry student at Loughborough University. Today I did my first ever local anaesthetic on a real patient, on a 12-year-old little boy. It was quite daunting because I'd just been practicing on fake rubber toes. And he was pulling and screaming away, so it was quite scary. And then I did also verruca needling as well. So I observed the ankle tibial block, but I did the actual procedure of the nail surgery and the local anaesthetic.
Brilliant.
Yeah, it was good fun. I enjoyed it.
And I'm Gaia, so I'm again at Salford University in my second year though. And then today I've been at clinic, so I'm based at Ancoats, and it's great. I treat routine patients, high-risk patients, all ulcers, everything like that. It's great.
That's fantastic.
Yeah.
So Alan, tell us a little bit about yourself for the people that are just getting interested in pharmacology.
Right. Well, thank you. First of all, thank you for inviting me to come along and chat to you all.
Thank you for accepting as well.
Well, not at all. A real privilege. Yeah. Well, I suppose my background is I'm an emeritus professor at University of Southampton at the moment, and I worked really on getting prescribing from about 2008. And it went on and on and on until effectively 2013 before it was all finally sorted out. But when I say finally sorted out, it's actually not finally sorted out, in the sense that we still have issues at the moment, which we've partially solved with control drugs. So nothing is ever perfect. But I'll come on to all of that as we go through the evening.
Brilliant.
Yeah.
So, Alan, are you going to take us through the brief history of our prescribing rights?
I will do, thanks. I'm going to have to ask SJ to come up with the presentation, I think. If we start that now, SJ, that would be great. What I'm going to do is show a few slides. There's probably too many slides really to cover, but I want to just try and give you a picture of the background first. Just to give you an idea of why it is that independent prescribing has been such a long and hard journey, because as you all know, medical doctors don't have any problems getting hold of any medicine they like, but all the other healthcare professions do have problems. traditionally, but there are a few allied health professions like our own that have come a long way quite quickly, really, relatively. Anyway, if we go to the next slide, SJ, that would be great. And I just wanted to include these two little quotes here to give you a sense of why things began to change, because we've been in and around medicines of a sort for 50 years or more in podiatry. But independent prescribing only really started to happen at the turn of the century. And that's all because the government was concerned about where the NHS and healthcare generally was going to go, because they realized that we had a bit of a workforce crisis approaching. We have a aging population, as you all know, and what that means is that most of the people, or a lot of the people in the health services, would begin to retire. They were part of a generation called the baby boomers. That's me. Anyone who was born between 1947 and 1963 is a baby boomer. So my mum and dad had 4 kids, and most people after the 1960s tended not to have as many kids as that. So that generation was quite big. Now they're all getting older and we're all retiring. And the government thought, we've got a problem here. How are we going to make sure that we continue to provide good healthcare? And one of the issues was we can't do it easily because there's not enough people in the NHS to provide it. And we see that now, don't we? Because there's loads and loads of jobs for nurses, loads of jobs for everybody, and we just can't recruit enough people. So you are all doing exactly the right thing, entering into careers in podiatry now, because you've got a great future ahead of you, because you're going to be in very high demand for the rest of your careers. But the reason it changed is because they needed to find a different way of doing things, because up until that time, it was doctors alone that really did the prescribing. Dentists had a bit, but it was mainly doctors, and no one else really had a good look in it. But as you can see from these two quotes, the top quote comes from our own British government at the time, around about 2000, and they talked about, we've got to do things differently, we've got new ways of working. And what does that mean? It means they've got to work across traditional professional boundaries. And that was the kind of thing they were talking about, expanding scopes of practice in professions that traditionally didn't really do these things because they were always exclusively medical tasks and only the medics did it. And now they said at government level, we can't carry on like that. Other professions I've got to be able to do it. And the second quote is actually from Nicola Roxon. She was the Australian health minister, and she captured it beautifully in that slide. Doctors will need to be prepared to let go of some of the work that others, like podiatrists, can safely do. And that included prescribing. So the door was open to that kind of change for us for the very first time. Okay, SJ, can we move to the next slide? So what were we contending with when this happened? And this is the complex bit, because already we had, from 1968 and 1971, 2 acts of Parliament that determined who could use medicines and who couldn't. And there was the Medicines Act, and there was the Misuse of Drugs Act, which covered controlled drugs. Now, podiatrists today, independent prescribers, use both. They use the medicines that are talked about in the Medicines Act, and also use controlled drugs, which are talked about in the Misuse of Drugs Act. So what we had to do was to try and change some of the provisions in the Act. And the way that you do that is to have this thing called the secondary legislation, which is commonly called a statutory instrument or exemptions. Podiatrists often call them the exemptions because they are exemptions to the Act. And you don't have to introduce an entirely new Act of Parliament to get a change. You just change a bit of it. And so everything is small, change a bit, slightly here, slightly there. And you have to go through this big process to get it all done. But the biggest step we had to do, of course, was independent prescribing. Okay, SJ, if we could just, okay, that's great, thank you. This is a definition from a particular report that was really important for us. It was published in 1999 by June Crown, and she was a public health doctor, and she was commissioned to do this. And basically, in her report, she said podiatrists should be able to prescribe. And that was revelation for us. We thought, this is fantastic. No one's ever said that before. When she talks about prescribing, when we talk about prescribing, we talk about this. That is to order in writing the supply of something called a prescription-only medicine for a named patient. Now, that's actually legally different from the other rights that we've had in the past. So we've had rights to supply and rights to administer. And SJ, if we pop onto the next slide, you'll see what they are. Supply is providing a medicine directly to a patient. Hand them a tube of something and ask them to apply it or something of that sort. That is a legal act of supply. Now, we have a list of medicines that we can access that it's got nothing to do with prescribing. It's to do with the rights that we had before prescribing, which were quite limited, as you'll see very shortly. And that's a separate list. So we've got one list for supply and a separate list for administration, which is, for the most part, as far as we're concerned, it's where you inject a drug largely into somebody. So they're not injecting themselves, you're doing it. Or you're applying a cream or something that's got a medicine in it onto the skin, but you're doing it, not the patient. That's administration. Okay, next slide, please. Just to clarify, and this is a bit complicated in a way, but nothing makes sense unless I explain it now, so I hope you don't mind. 3 different categories of drugs in the Medicines Act, and it all depends on how dangerous they are, really. The general sales list drugs are the ones you can pick up without any real restriction. Go to the supermarket, buy it, and pop it in your basket and go and pay for it, and that's it. Pharmacy-only medicines, you can't quite do that. You've got to go to the pharmacy counter and ask the pharmacist or whoever is serving behind the counter, could I please have this medicine that's over the counter? And they can provide that. But then the third category is the drugs that were largely restricted to doctors to supply, to prescribe. And they're called prescription-only medicines. Now, we, over the years, from 1980 onwards, were able to get some, but usually only in little batches of about 4 medicines. And then a few years later, we'd get some more. And we had, the first one was in 1980. We got 4 local anesthetic agents. Then again in 1998, long gap. Then again in 2006, and again in 2011. So very, very small numbers of medicines that we were able to pick up that were both pharmacy only and prescription only. If we go to the next slide, it's left us with different mechanisms for getting medicines. The exemptions, which are the supply and administration ones that you know about, you use. Patient group directions, I won't go on about those too much. And then supplementary and, of course, independent prescribing. So that kind of gives us some sense of the background. So if we go to the next slide, that's great. This is the list. Now you can see how limited the lists are. There's 2. There's one for sale and supply, which you see here. 11 medicines on the list. 3 antibiotics. It's a good example, actually, to use the antibiotics because the one problem with using exemptions like this is that you're restricted to exactly the medicines on the list. Now, how many people actually use erythromycin today? Very few, largely because there's a new generation of broad-spectrum antibiotics for penicillin allergic folk, and that tends to be clarithromycin. But just because a new medicine comes along and supersedes the old one doesn't mean that we automatically get it, and that's the problem. So you get stuck with these medicines, which are a bit limited. If we go on to the next slide, you can see the list of drugs that we can administer, mainly local anesthetics, but we also have a steroid, methylprednisolone, and adrenaline. But again, there's only 11 on that list, so it's quite restricted. And the medicines don't change. So if there are new generation drugs that come along that do the same thing, we can't have them. We've got to go back to the drawing board and go through the whole process of asking for them again to get the law changed to do it. And that's a nightmare as a rule. Okay, next slide. you may. And that's where this thing called the Crown Report came in and was so important. And they talked about having 5 categories of professions that would use independent prescribing. And I'm going to really focus on that. And podiatry was one of them. Optometrists were the other named ones, alongside physiotherapists and a couple of different versions of nurses, family planning nurses and wound care nurses. Okay, next slide, please. Supplementary prescribing was what we got first. And that was a deliberate approach, a stepwise approach that the governments said that they would do. So we had to go there first, get into supplementary prescribing before we could be considered for independent prescribing. Supplementary prescribing is pretty good, but it is limited in the sense that you basically have to depend on a clinical management plan that's drawn up by an independent prescriber, a doctor mainly. That's how it worked. So we could prescribe medicines, but only once it had been agreed. So the roles were still duplicated, and they were limited in what you could do with supplementary prescribing. So if we go to the next slide. This is the HCPC figures, the exact figures. Now, they're a bit out of date because the HCPC hasn't published any updated figures, but it gives you some sense. This is about a year ago. We had 576 podiatrists out of a total of about 13,000 on the register. 1,728 physios. There's about 48,000 physios on their register. So you can see the relatively small numbers in the profession. Mm-hmm. And that's for supplementary prescribing. Okay, if we pop onto the next slide. When independent prescribing came on, sorry, the slide has got one of my pills sitting across the G of prescribing. That's not deliberate. Anyway, the big question is independent prescribing the same as doctor prescribing? And the answer is no, it's not quite the same. Doctors can pretty well do anything they like, but it's not bad. Independent prescribing does give you access to every medicine in the British National Formulary, except controlled drugs and unlicensed medicines. But if you're a podiatrist and you're an independent prescriber, you can mix medicines, which no one else can, not any other podiatrist. If you're not an IP, you can't. And you can use off-label prescribing. That's where you prescribe a medicine which actually has a specific use in it's intended for one use, but you're using it for another. So if you think of amitriptyline, it's actually used as an antidepressant, but we use it sometimes because it helps with diabetic mononeuropathy, the pain. So it's a different purpose that you're using it for. Okay, if we move on to the next slide. Actually, we can move on from that slide. Next slide, that'd be great if you don't mind. Thank you. Yeah, here's the figures from December 2021. Again, you can see slightly fewer podiatrists as independent prescribers than were supplementary prescribers. That's just a throwback really to the fact that supplementary prescribing started a long time before independent prescribing. We got supplementary prescribing in 2004. So people were training in 2005, but we didn't get independent prescribing until 2013. Really, when the law was changed to allow it. So there's a bit of a gap. That's why there's more supplementary than independent prescribers. But again, small numbers relative to the profession sizes. If we go to the next slide, you can see the difference. But what you do see here is that podiatrists punch above their weight when it comes to comparing us with the other professions who are also independent prescribers, with the sole exception of optometrists, but optometrists have been doing it for quite a while. And their uptake is very strong, relatively 5%, but we're not too bad at 3.4%. That was early last year, April. These are figures for April of last year, but still slightly higher than physio. And Matt, when you listen to his presentation, he'll talk a little bit about that too. Okay, next slide. I thought you'd be interested, and Sophie was talking about this earlier, actually, before we were on air, about the number of people on annotations. These are the HCPC figures, again, from last year, but it does show that an interesting feature, which I think has been confirmed by Sophie's recent work that people use local anaesthetics more than they use their supply and administration lists, and you can see that reflected in the figures. So that's quite an interesting phenomenon for all of us to consider. What might the reason be for that? I'm sure we're going to talk about that too soon. Okay, next slide. Now, one of the things that the authorities that we had to convince, the big authority is called the Commission on Human Medicines. And when we wanted independent prescribing, we had to submit to them. That is to say, we had to go to this big meeting, and there were 25 or 30 people around this big table, each one with microphones. And quite a scary kind of combative meeting, because you need to convince these people, the senior medical people, etc., that you're going to be able to do this independent prescribing and not mess it up and not be unsafe, and that you know what you're doing and you're properly trained and all that kind of stuff. And one of the things that they said at the end is that although with independent prescribing you do have access to any medicine in the BNF, with the exception of unlicensed medicines and control drugs, but you can't just go off and, prescribe Viagra to your friends if that's what you want to do. You can't do that kind of thing. You've got to restrict it in some way. And the way that they said that we should do that is to have a professional body scope of practice statement, and this is it. So basically, we had to say you can prescribe medicines providing it's relevant to the treatment of disorders affecting the foot and associated structures. So that's the way to kind of get podiatrists and physios. They had their own statement. They had to do that too. So did everybody else, just to make sure that you were going to follow good governance and prescribe for the things that you should, and not prescribe for the things that you shouldn't. Okay, doke. Next slide. If we scan past the next two slides, because I'm going to come back to that in our discussion later, because I think a number of people have wanted to ask questions about how do you become an independent prescriber. So I'll talk a little bit about that later. This is the list of control drugs that we have. So when we got independent prescribing, we actually had to have a specific list. We had no choice. We had to have a list for control drugs. These are drugs that are particularly, hazardous if they're misused. So they're classified not only under the Medicines Act, but also under the Misuse of Drugs Regulations and the Misuse of Drugs Act, which comes under not the Department of Health, but comes under the Home Office. So we had 4 that we applied to get. And you might think, well, why did you only ask for 4? And the reason effectively was, you kind of know when you're in this business that you can't go in asking for too much at once. You've just got to take it step by step and build it up over time. So we thought it would be sensible to go in and ask for 4. Of course, the physios ended up asking for 6 and got them. So there we go. Okay, next slide. In fact, we can go past the next slide as well, and that slide we can go past. Now, this is the current project, or one of the current projects, which hasn't completed yet, but it's ongoing as I speak. We wanted to access these 4 medicines simply because pregabalin, gabapentin, and tramadol were drugs that were used, well, pregabalin and gabapentin by diabetes specialist podiatrists, and tramadol particularly by podiatric surgeons. And if for those who were independent prescribers, they could access these medicines, and then suddenly the law was changed for each of these medicines, and they were reclassified as control drugs, Schedule 3 control drugs, which suddenly meant that podiatric surgeons and diabetes specialist podiatrists who were independent prescribers could not access the drug anymore. So when that happens, and sadly it does, you have to go back to the drawing table and go to the Department of Health, the NHS England, and get the medicines project started again, and go back and ask for the law to be changed to allow these drugs to be added. So to give you a sense of the timing, these things were worked on initially. I think that started out in about 2019, perhaps 2018. We haven't had a final answer yet. The presentation was earlier this year to the Advisory Council on the Misuse of Drugs, but they haven't. They've asked for some changes to be made, so we don't know whether we're going to get them or not. Okie doke, next slide. I've kind of mentioned that, so we'll move on. It's a bit dry, that one. But if you noticed in the exemptions, we had a list of 11 drugs, which I talk about for sale and supply, which included codeine products, these three: codeine phosphate, cocodamol, and codidromol. But in 2019, I became conscious of the fact, because I was chair of the medicines committee at the time of the Royal College of Podiatry, that we were running into some kind of trouble here, because people were supplying these to their patients. It's written into the Human Medicines Regulations, which is the amendments to the Medicines Act, and that's fine. It says you can use them as podiatrists, but there was a mistake made along the line, which meant that the Home Office didn't add them to the misuse of drugs regulations. So I spoke to our contact in the Home Office and said, I think we've got a problem here. And she looked at it and said, oh, you do, because the misuse of drugs regulations trumps the medicines legislation if you're talking about controlled drugs. So we had this problem, which we faced in the past, where podiatrists are supplying medicines to patients which technically, in the law, they shouldn't be. So what we had to do is go back and find a solution to the problem, try to do that, and luckily it worked. If we go to the next slide, thanks. That just outlines it, but you can see how recently we managed to solve that problem. I had to work with Sheila Morris at the Department of Health, well, NHS England, to go before the Advisory Council on the Misuse of Drugs. That was in February of last year, and we actually didn't get a decision on it finally until June of this year. But luckily, they've said, carry on as normal. We're going to add it, add these drugs, so that we'll be okay. But that gives you some sense. That's basically it. That's the presentation. So thank you for listening to that. I hope that wasn't too boring and complicated, because these things can be a bit complicated. But it shows that independent prescribing is great, but there's still more work to do. And I think that's the point at which I'll stop now, Sophie, and pass it back to you.
That was brilliant, Alan. Thank you very much.
I think that was super interesting. I'm definitely going to go back and do a reflection on that for uni.
Oh,
Yeah.
okay.
Now we've got Matthew Fitzpatrick on independent prescribing.
So I'm a huge advocate of prescribing. The 2021 HCPC statistics show that about 4.1% of the current registered podiatrists are practicing IP or have completed the IP course. For our colleagues in paramedic practice, that is around 2.6. If I remember correctly, I think our colleagues in physiotherapy are under 3, and those who are radiographers who have been able to access IP more recently than physiotherapy and podiatry, I think they are under 1%. So out of all the AHPs, we're the highest user by percentage of our professional bodies, but certainly it's something I want to see grow. We definitely see it more in our podiatric surgical colleagues, our colleagues who work in high-risk foot, rheumatoid arthritic patients, usually those with more long-term conditions as well, where they need to have that co-management and MDT approach is one to also be aware of. Yes, I'd love to see it expand and grow, and I'm not going to talk about future opportunities in terms of training and expansion into undergraduate programs. I'm sure Alan will pick up on some of those points as well, if not already. But the opportunity to develop ourselves, situate ourselves, reduce the burden on practice of our other colleagues within the MDT, I think it's behest upon us to utilise, train and then develop our use of this particular access to medicines management. So I don't anticipate overnight we're going to be at 50%, but I would hope in my lifetime, as my career, as I'm involved and still linked at the Royal College, that I'm able to look back and see, you know, us getting to maybe 10 or 15%. As we progress as a professional body in this area, IP has the huge implications of being able to reduce patients from having to go to this person, to that person, to this person. It helps us support the wider network. It doesn't mean we act independently. We should always be linking back to primary care physicians, GPs, and other specialists who are looking after that patient. So we're not prescribing in independence, although it's independent prescribing. It's a collegiate approach to holistically manage the patient that's in front of you.
That was brilliant from Matt. So we've got a statement from an independent prescriber. So this is Stephanie Stanley, and she's a consultant podiatrist. There's Stephanie, from the Isle of Wight, the NHS. So we're just going to paraphrase what she said, but we will upload the statement later on. So she said that when independent prescribing was introduced, she thought it was a fantastic addition to a podiatrist, though that there was other people working in the diabetic related issues. She felt she wasn't up to the standard to like consultants that were working there that could prescribe. Also, there was a problem with funding as well. But then as times changed, especially during COVID-19, when GP appointments were difficult to get and diabetes consultants were working in the ward, she felt like it would have been a disadvantage. So in 2019, a year before COVID, she became an independent prescriber, and she's found that it enabled a holistic diagnosis and subsequent provisions of a prescription at the time for treatment, and to ensure that there's no delays in getting the medication in a time-sensitive manner. Also, she said she's very privileged to have a committed and accessible designated medical practitioner who's always there to assist her when she has concerns, and also a team consisting of a microbiologist and an antibiotic pharmacist, all of whom have a wealth of experience and knowledge and ensure that the decision-making process is dealt with. Freya?
Steph also said that she said it wasn't easy, but it was also necessary to do it. She also said that being a prescriber is a privilege, and she uses it every day for her medical and non-medical prescribers who assisted me in getting her qualifications. What else did she say? She said it's really good for CPD. And she said that she enjoyed it. It was a big challenge for her to actually complete it.
Because it's so important.
Yeah, she said it was really crucial that she needed it. And it helped her with her general practice and helping clinics.
I think it's brilliant, her saying that she has a healthy fear of prescribing as well. She don't want to be all guns blazing with the British National Foundry going, yeah. You need to have that. I think she describes it as, hang on, where is it? Disappeared from me. De-prescribing rather than just always prescribing. Because we did it a few weeks ago in class where we look up a drug and then you look at the contraindications, the interactions, and it's quite frightening how a lot of them can interact, and especially with people on, like coming in like polypharmacies on different medications as well.
No, definitely, Sophia.
Yeah. As well, so a poll was taken on Facebook, and it was basically saying how podiatrists are using their prescribing rights. So the different polls. So it said, I'm an independent prescriber and regularly use my practice. So only 20% said that. Where the podiatrists who have done POMs, but mainly only just use local anaesthetic. So that's around 30% of podiatrists. Yeah, it's quite interesting to see the different people.
There was an interesting, not so much a divide, but difference in answers as well in comparison to the Facebook poll, to the Twitter poll, where more on the Twitter side were saying that they were independent prescribers and regularly use it, whereas like Gaia was saying, the Facebook poll showed that more people were actually using the POMs. So it's kind of not nice to see the difference, but it'd be interesting one day potentially to get a broader spectrum and try and merge those together and make sure there's not like double people replying on both.
Definitely. So we've got another video from Matthew or Matt where he discussed local anaesthetics.
My biggest passion, for anyone who's ever heard me and any Southampton students who I've lectured to in the past, or any who've been to some of my talks, I'm a huge advocate of the use of local anaesthesia in the management of patients. And I always start with this story. I'm not a dentist phobe, but I don't go running to the dentist just for fun. But I wouldn't or couldn't imagine subjecting myself to sitting there while the dentist is drilling into my tooth to put a filling in without an anaesthetic. It would be an anathema to me, although my dentist did once say that he'd probably just get away with not having to, but it wasn't quite deep. There was just no way I was going to tolerate that. Now, some people may be a little bit more tolerant to that, and if anyone's ever seen The Little Shop of Horrors and the scene from the dentist there, older people will recognise and remember that. If not, go and watch it. It's a really good musical. You can download it on various platforms, I'm sure. But there's a patient in there who loves pain, and he goes to see the dentist because he wants that pain stimuli. But I'm certainly not that person. And so I will say there's always been an anathema to me is why we put patients through discomfort and pain and trauma when we have the ability to anaesthetise an area, when we are enucleating a very deep, painful corn, one that usually are vascular corns, or those of our patients who are rheumatoid arthritic and they've got significant plantar fat atrophy, and so they get the development of hard skin, diffuse callus that can then have that pinpoint areas that spread over the foot. And then we have to go through and treat and enucleate, and for some reason we seem to think that local anaesthetic is only there either for podiatry surgery or nail surgery, whereas actually I think it's a resource that should be made more available or utilised more both in the NHS and in the private setting. So I think we need to understand that we're always striving and saying we want to have access to more, we want to extend our scope, we want to do more as podiatrists, but actually we need to also consider what we already have at our disposal. And I'm a big champion of going and using the options of local anaesthesia. Now, local anaesthesia is also useful not just in treatment, but it can be used as a diagnostic tool. So sometimes where a patient comes in with a pinpoint area of pain, and you try and narrow it down, do you think it's neurological, do you think it's physical, or is it mechanical area? But sometimes just a small amount of anaesthetic in an area, then sending a patient away, and then coming back going, yes, the pain is absolutely gone, and you can pinpoint it to a specific area. It sometimes can help develop and enhance your diagnostic tools. And again, that's something that I've tried to employ when I was practicing in the UK.
Thank you for that, Matt. So, guys, why aren't people becoming independent prescribers or using their POMs fully? Oh, hang on, we've got something from Helen. So I did my prescribing in 2018 and use it in general practice and occasionally in my private practice.
Well done, Helen. That's good.
That's fantastic.
I think not many people know about how to become one. I think it's going to be. I'm really looking forward, Alan, for you to tell us all about it further on in the show.
Yeah, it's interesting as well that Helen, she said she uses it in her private practice as well. And a lot of people don't realise that. They tend to think, "Oh, I have to be in the NHS to use IP," but you don't. You can use it as Helen says, in the private sector as well. So it is a shame in a way that not as many people use it as we would like, but it's something that needs to be grown in a couple of ways, because one of the reasons that we haven't got as many people as independent prescribers is because there are some restrictions on who can do it, and when we come to talk about how do you become an independent prescriber, I'll mention it then.
Definitely. So we've got another of Matt's videos, which is on steroids. So that'll be interesting.
the option and a huge advantage that we have, which is one of the drugs available to us, is the injection of methylprednisolone, or depemedrone as its trade name. And I think it's something that, again, we've got to be very cautious and very well aware of the use of these steroids. They're not just to be used lightly. They can have side effects, which I'm not going to go into here because this is not a strictly pharmacological lecture. This is more about the practice and principles and sort of extolling the virtues of what's available in our scope of practice. But I had a huge benefit of using methylprednisolone, especially in my rheumatoid patients, a lot in my sports patients, those with neuromas, those with ganglions, for the treatment of tendinopathies, capsulitis, joint sinus tarsi syndrome, retrocalcaneal problems, inflamed fat pad. I mean, a huge number of clinical applications that I think, again, it's something that's underused and under-resourced in our practice. I think, we have this available to us, but we seem to think, oh, it's just for them to use, or I don't need to use it as much. But I think, if we can get and address pain early, and we can get people mobilizing and using their foot and getting the soft tissues functional quicker, I think I have seen over the years a much better clinical outcome in our practice. So again, I haven't even really started to touch on independent prescribing, and there's all these things that are available to us that I don't think we use enough.
That's fantastic. It's incredibly inventive the way he utilises his POMs.
Definitely.
Fantastic.
Really good.
Yeah.
So,
Matt is a fantastic advocate of this. His work on the Independent Prescribing project was of inestimable value. He was a real leader in the profession, and we all owe him a great deal for that. He's a good guy.
He's brilliant. Yeah, he came in for a lecture and he was just, he's fantastic. Very talented man.
Yeah.
So the possibilities of IP then. So I'm thinking, guys, what do you think about merging these two in? So Alan, the barriers to private and NHS practice with independent prescribing. So I'll rephrase that a bit better. With independent prescribing, how does one become one, and the difference between as a private clinician and an NHS clinician?
Yeah, thanks. And in a way, if we look at this, you can begin to see why it is that we don't have as many independent prescribers as we want. It's not because people don't want to do it necessarily, although confidence is always an issue with these things. But there is a document that we had to write, basically, with NHS England when we did independent prescribing. That was a requirement, called the Outline Curriculum Framework. And that specifies to all the universities who are going to run the program what it is they have to do. And there are a number of things. First of all, the obvious stuff. So obviously you have to be HCPC registered. Well, that goes without saying. But you have to be practicing where there's an identified need. And you might think, well, how do we define that? How do we get that? Well, it comes from the fact that in order to get on an independent prescribing course, your employer, if you're in the NHS, has to say, we have a space for an independent prescriber. So that's what it means when there has to be an identified need. And of course, because a number of different professions can be independent prescribers in the NHS, if there's a availability for one or two people in a particular unit or something to do it, they might pick a physio, they might pick a podiatrist, who knows. So you have to have an identified need and your employers have to put you forward for it. So that's a bit restricting. And you have to demonstrate the support of your employer. And that includes having someone who's going to act as the clinical supervisor, the DMP, the designated medical practitioner, in advance. So before you apply to the course, you've got to have a DMP lined up. Now in the NHS, that's possible, but it depends on where you work, really. But
does that mean that the clinical supervisor also has to be a prescriber then?
Yes, that's right. Now, up until very, very recently. In fact, I think for AHPs, it might still be the case that it still has to be a medical practitioner. The DMP is a designated medical practitioner. Now, there have been moves recently, particularly in nursing. They have decided to move forward to acknowledge independent prescriber nurses can now be the equivalent of a DMP. But of course, for the allied health professions, we haven't got quite the same capacity to do that, because there's many, many more nurses who are independent prescribers than there are AHPs, because they've been doing it for longer. So we're not quite at the stage yet where we've got enough people who could be supervisors at DMP level. But that seems to mean that's one of the restrictions that makes it a little bit tricky. Not impossible, but it does make it a bit difficult. But the good news is, if you in your own private practice, you're your own employer, so you can decide that there's an identified need. So you don't need to go through the red tape that somebody in the NHS might have to go through. You can just say, well, I'm the employer, I have a need for my patients.
Mm-hmm. Alan, I have a question from someone asking, how long is the course?
And what are the requirements as well?
Yeah, okay. Well, the course is, to be absolutely specific, it's 38 days in total. 26 days are allocated to theoretical training, so you go to lectures at the university. How the university runs it may vary. You know, usually they do 1 day a week for 3 to 6 months, something like that. So to train up to do it. So you go to the university to get the theoretical training, but you also have to have clinical training with this designated medical practitioner, and that's about 12 days, about 2 weeks roughly. So it's, strictly speaking, it's 12 days at 7.5 hours per day. That's what it says in the document. So it's a minimum of 90 hours of practice-based learning. So that's what you have to do. So you need to find a DMP who's willing to give you 90 hours to supervise you as you go through prescribing in practice.
Okay.
It has to be delivered over a maximum period of a year, but for the most part, it's usually within 3 to 6 months. You can complete the course. So that's the duration. That's how long it takes. And Steph, in her statement that you and Sophie read out earlier, makes the point. It's it's a bit tough at times to do it, but anyone who does go through it gains a lot of confidence, because if you've been trained as we have in podiatry at undergraduate level in pharmacology, you never quite know whether the pharmacology you've got is going to really be enough to help you through the IP course. But one thing that's really interesting about all of this is that last year I was speaking with Sheila Morris, who worked, she was the Deputy Chief Allied Health Professions Officer who ran the Independent Prescribing project. And I said to her, so this is some years after we'd completed that work, and we keep in touch. And I said, do you think that it will ever be the training will ever be at undergraduate level? Because at the moment, one of the other criteria is that you should be familiar with the medicines that you will be using for a 3-year period. So you should really be operating at a kind of advanced practitioner level before you apply for the course. So if we moved it to an undergraduate program, that would be quite a big step. And I just asked her, do you think it's possible, sometime in the future? Would I see it in my lifetime, that kind of thing? But her answer was really interesting, because she said, well, actually, Alan, I think it could happen very soon. I think there is a good possibility that independent prescribing might become part of the undergraduate program much sooner than we think. Now, I can't guarantee it, she said, but that's something that...
to go and do the actual degree as well.
Yeah, definitely.
Yeah, I mean, absolutely. It would be a major step forward. I know the nurses are thinking of this, of looking at ways in which they can incorporate the training into undergraduate level. But that's really quick, isn't it? If you think it's 10 years, well, 9 years, we'll say, since the law was changed to allow independent prescribing. And at the time it said you're going to be in practice for 3 years, and now they're beginning to talk about doing it at undergraduate level.
Also, we can implement that into undergraduates, then that kind of takes the problem out of newly qualified podiatrists with the limited list of POMs as well, especially with the antibiotic side to it.
Absolutely right. Yeah, I mean, the list of POMs they're useful, but they're not that useful.
Sorry, Ferring guy, you keep cutting in and out with your mics.
Oh, is the Wi-Fi not great?
Oh, it's working now.
Oh, good. I was saying, yeah, our POMs, I don't know about at your university, but it is quite a short module, and I think I'm in third year. It's quite scary that I'm going to be graduating in May. I've only done mine was an assignment. It wasn't even an exam. So
it'd be good to look.
It'd be really to go over and understand it before I go into the NHS and graduate.
Yeah, because we have 2 exams, and we've had about 2 full days a week studying pharmacology, and then one of our lecturers had given we all got given a BNF each, and then we'd go through like the drugs that we'd kind of see in the clinic, and then think of all the interactions and everything just to get that in your head and get the seriousness of misprescribing. So
yeah,
it's terrifying, but it's brilliant to not go all guns blazing thinking, oh yeah, I'm going to prescribe that. You need to be thinking what's the consequences here. Be really safe.
Definitely. I think we've got one more video going.
Yeah, so we've got one more video. Is anything else that you guys want to say, by the way, before we put the video on?
Alan, in a perfect world, what would you change if you could?
Oh, in the perfect world, I think probably actually moving to have the independent prescribing at undergraduate level, because it would remove all the complexities around having to show an identifiable need, etc. Because by now we all know, even at policy level, people know that prescribers in professions like podiatry and physiotherapy are going to be immensely helpful in solving the workforce problem that is engulfing us at the moment. We can see it all the time when we listen to the new Prime Minister and the previous Prime Minister and the previous Prime Minister to that. One of the issues that they're grappling with and struggling with is this simply not having enough people who are trained to do these jobs in the NHS. And it's not a problem, as we know. It's not going to go away anytime soon. It's going to get worse before it gets better. So they need these solutions, and we could be part of that solution. So for me, anything that would make independent prescribing more accessible, because if it's more accessible to us as podiatrists, it's going to be more accessible to the patients, and that's the name of the game.
Also, in some diabetic clinics, do you think there's some reluctance of podiatrists becoming independent prescribing just because of the worst comes to the worst type things?
Yes, I think that's probably true, in that if you look at the cases of litigation that come up before the Royal College of Podiatrists, which obviously represents its members if they ever have to face cases of litigation. Sadly, use of medicine, not prescribing actually, isn't a particularly big thing, but we have in the past had instances of things going a bit wrong with using some medicines like liquefied phenol. That has been a bit problematic in the past. There's been 1 or 2 scary things that have happened there. And it does make people fearful, because you think if you're taking on such responsibility, you first of all, you want to be covered for it. You don't want to be exposed. And the Royal College of Podiatry does do that. It does provide good cover for members, so we don't need to be worried about that. But it's a very, very traumatic thing to have to go through a litigation case. And I've seen several in my career, over 40 odd years. These things do happen. Even when, people are, they're not deliberately doing these things, and they're not negligent necessarily either. They're just unlucky at times. But that I think does have a bearing on it. But I would encourage people to go ahead anyway, because if you're well trained, then you know what you're doing. And we all have a responsibility to do our best to make sure that we know what we're doing. And if you do that, the rewards are huge, not just for the patient, but actually for you too, because you can go home at night thinking, well, I've done a good job there. I've actually really helped somebody.
Just to add on to that, I've seen a lot of positively strong feelings on getting my team upped in the ante in terms of being independent prescribers, because the majority of our patients are high-risk diabetics with ulcers at risk of infection. And like you say, it can just do a world of wonders being able to provide that treatment so much quicker with staff that are able to do so quite immediately.
Yeah. See, for someone of my age, Lucy, it's tremendous to hear you say that and to know that you and your colleagues have that enthusiasm and that desire to do it, and because you'll succeed with this, because the policy door is open to allow this to go. So we've got the green light for the most part, but yeah, we're dealing with one or two little bits. The controlled drugs are always a bit of a problem, but we know that because there's this great public concern and policy concern about the opioid epidemic and all that kind of stuff. So that makes getting controlled drugs a bit harder. But that aside, yeah, it's great to hear people like yourself and your colleagues doing this kind of work and showing the desire to go on and do it. And I would really encourage you all to give it a go, because you can do it. You can all do it. You're all qualified enough. You're able to get on and do it and go for it.
I think there's another question as well. So how do we get more info about independent prescribing?
Yeah, I guess the thing is the universities that run the programs. There's lots and lots of universities. I've seen a list not recently, but I have seen the list on the HCPC website, which shows all the different universities that provide independent prescriber training. Most of them are multidisciplinary because they don't. There are one or two independent prescribing programs specifically for podiatrists. There's one or two in Northern Ireland, I remember. University of Ulster, for example, but most of them in England and Wales and Scotland tend to be multidisciplinary, so they're for physiotherapists, podiatrists, radiographers, and so on. But
Brilliant.
Yeah, if you see the local courses advertised in the universities near where you're working or living, you can check it with them, and they will tell you. They'll give you all the details you need to know about how to get on the course, what the requirements are, because they're all working to this document I talked about earlier called the Outline Curriculum Framework. So the things that I mentioned to you about 38 days in total, blah, 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 and the costs, they'll give you all of that and let you know. And their admissions people will tell you if you've got all the admission criteria, etc. So the universities are the places to go. The ones that are running the programs, go and ask them. Usually they'll be in the Faculty of Health.
Also, when someone qualifies as an independent prescriber, is there a maintenance or like a portfolio they have to keep?
Yes, absolutely. Yeah, they do. That's absolutely spot on. So if they have obviously anyone in healthcare nowadays has to be seen to be doing CPD, continuing professional development. That's a requirement outlined by the regulatory body, the Health and Care Professions Council, HCPC. So if you're not doing it, you won't get registered again, because they'll pick you out and say, well, you should be doing this. And if you're not, you won't get registered. You'll have to go back and take remedial action. So any special skills that we get, we do have to do CPD. And it's done by a portfolio. And I think that's the best way to do it. Because it's like building up your CV in a sense, and so you're able to demonstrate how many cases you've treated with this and that, the outcomes, etc., etc. So it's a really good piece of information, feeding in data. And of course, the professional body has used various database systems like Pascal to collect data. The podiatric surgeons have been doing it for years. And again, Matt Fitzpatrick is the man who turns up everywhere, doesn't he? He's had a big hand in developing the Pascal system for collecting data where which is useful from your portfolios to give national level data on what sort of drugs podiatrists are using in each specialty area. Obviously, podiatric surgeons use a different set to people in diabetes care, etc. So CPD is a requirement, but the portfolio is the way in which you keep up to date and maintain that. And that's checked every now and again, every 3 years by the HCPC.
I think we have one more question. So Cockermouth Podiatry asks, what cost is involved if you are in PP?
Yeah, I can't remember exactly what the current costs of independent prescribing program were, but I think a few years ago it was in the several hundreds of pounds. I can't quite remember off the top of my head what the costs were, but they're not completely unmanageable. I think it was £900 or something for one of the programs at the University of Southampton, but that would have been about 5 years ago. So in that time, gone up a fair bit. But yeah, some of you out there might be able to tell us as well exactly what you've paid for it. But I'm obviously in private practice, it's coming out of your own pocket, so you kind of need to be assured of that. But again, if you have a query about that, check it with your local university, the one that runs the program, and that's the first thing they'll tell you is how much it costs. But I've never found it to be completely unmanageable. You know, it's not in the tens of thousands or anything like that. It's not like an undergraduate program. Yeah, it's nothing like that. Yeah, a couple of thousand to do it.
Off with Matt's video then.
The medicine story is going to continue long after Alan and I and others are around. And I think that's the exciting thing about it, because it's forever changing. It's an evolving, it's an adapting and a reflective process, which is what medicines management is. It's constantly looking at what we could be doing better, what can we be removing from the pharmacopoeia of things that patients take, the polypharmacy nature of some of our patients, but also where inappropriately when we intervene and we add something in there for the benefit of our patients.
So just want to say thank you so much, Alan.
Thank you.
Yeah. For today, it's been really interesting.
Thank you. It was a pleasure to meet you all, and thank you for inviting me again. I think it's great to have people like Matt around as well doing his pre-recording.
Yes.
So
I will send an email to Matt to thank him as well. Yeah. It's been really interesting. Thank you very much.
Thank you. And thank you for everybody for joining us.
Yes, I hope you've all enjoyed it. This is going to be a few months till our next back. I think it's going to be in February.
After exam.
Yes, and 2 lots of placements as well. So, no, actually, it has to be a placement.
Placement Monday.
Do you? Oh, nice.
5 weeks, Monday to Friday. So it's going to be very intense.
Nice. 14th of November, I start mine.
Oh, exciting.
I am.
Okay.
So thank you again, Alan. Thank you, guys. Thank you, everybody, for watching as well. It's been a really fun night.
Thanks.
Yeah. Hope you all have a lovely evening.